Migraine headaches, how to treat and prevent them. Part 2A, acute treatment of migraines, OTCs, Triptans, and Ergots. Hi again everyone, and welcome to the PharmEasy Tutor. We previously presented an overview of migraine headaches in part 1 of this series. Now we will move on and discuss the acute treatment of migraines. Because of the length of material in part 2, I decided to split it up into two sections. Part 2A, which will go over OTCs, Triptans, and Ergots, and Part 2B, which will cover the newly approved agents, the gepants and the ditans. But first, let's review a few things. A migraine headache is a type of headache of moderate to severe pain intensity characterized by a throbbing, pulsating, or pounding pain sensation. There are two main treatment approaches that use medications, abortive and preventive. Drug therapy for migraine is divided into two categories, abortive and preventive treatment. Abortive or acute medications are taken as soon as migraine symptoms occur to relieve pain and restore function. Preventive treatment, on the other hand, involves taking medicines daily to reduce the severity of future migraine attacks or to keep them from happening. Today, we'll be talking about the abortive or acute medications. The acute treatment of migraine headaches, OTC drugs. Over-the-counter or OTC pain medications are effective for some people with mild to moderate migraines to help reduce their symptoms. Here are some advantages of using OTC analgesics. They are available without a prescription. They are non-narcotic. They're accessible. The cost is low compared to prescription medicine, and they can be taken for migraine with or without aura. The most widely used first-line OTC treatments for mild to moderate migraine attacks are non-steroidal anti-inflammatory drugs or NSAIDs, such as ibuprofen and naproxen. They are low-cost, over-the-counter analgesic medications. NSAIDs are popular mainstay choices and have the greatest strength of evidence. Other popular ingredients in pain-relieving OTC medications are aspirin and acetaminophen, used alone, together, or in combination with caffeine. In placebo-controlled trials, acetaminophen was less effective than NSAIDs, but did not cause gastric irritation or antiplatelet effects. Let's take a look at a comparison table of OTC drugs used for acute migraine. The first drug is acetaminophen or Tylenol, which is best for mild pain. It can be combined with aspirin and caffeine. It doesn't ease inflammation. A main caution is that taking too much acetaminophen can damage the liver. The maximum daily dose of acetaminophen should be 3,000 milligrams or 3 grams per day. Here are some over-the-counter non-steroidal anti-inflammatory drugs or NSAIDs, ibuprofen or Motrin, naproxen or Aleve, and aspirin or Ecotrin. The mechanism of action of NSAIDs is that they inhibit the cyclooxygenase or COX-1 and 2 enzymes to prevent the formation of prostaglandins that cause inflammation, pain, and swelling. Caution: high doses or prolonged use can cause stomach upset, GI bleeding, or kidney damage. NSAIDs can reduce inflammation, so it's a better choice than acetaminophen to alleviate pain. Naproxen has a slower onset of action, but a longer half-life. And aspirin should not be given to children due to the risk for developing Reye syndrome. Here are some over-the-counter combination analgesics: Anacin, which contains aspirin and caffeine, Excedrin tension headache, which contains acetaminophen and caffeine, Excedrin migraine, which contains acetaminophen, aspirin, and caffeine, and Advil and Motrin Migraine, which contains solubilized, liquid-filled capsules. These OTC analgesics tend to be most effective if taken at the first signs of a migraine attack, early in the headache phase, when the headache is still mild. This gives them time to absorb into the bloodstream to ease symptoms. Don't wait until the headache worsens to take painkillers, as it's often too late for the medication to work. Let's talk a little bit about medication overuse headaches. Taking over-the-counter pain-relieving medications too often can trigger serious analgesic overuse headaches. They are sometimes called rebound headaches. A medication overuse headache is defined as a chronic daily headache or increasing headache frequency resulting from regular overuse of analgesics for migraine by patients who have at least 15 days per month with headache. Here are some important characteristics of medication overuse headaches. Analgesic overuse headaches can occur if OTC pain medications are taken more than 2 to 3 days per week. The risk of these headaches seem to be highest with caffeine-containing combinations and lowest with NSAIDs. Analgesic overuse headaches have reduced efficacy to acute drug therapy for migraines. They also tend to be more refractory to preventive or prophylactic medications. If analgesic overuse headaches occur with the use of OTC drugs, switching to prescription medications may be more effective. What should you do if OTCs don't work? The patient should be referred to their primary healthcare provider when over-the-counter medications fail to relieve headaches and are not reliably effective. When OTC medication use is more frequent than 2 to 3 days per week, or the patient spends fewer than 15 days a month headache-free, when more than 50% of their migraine headaches are disabling, when more than 20% of their migraines are accompanied by vomiting, and when the patient does not have relief in at least 2 of 3 treated attacks. In these cases, the physician may start prescription migraine medications. Sidebar: a word about opiates. Consensus guidelines advise against the use of opioids such as codeine and barbiturates in the treatment of migraine because of adverse effects and the risk of dependency. Opioids are not any more effective than OTC painkillers for migraine. Opioids can cause nausea and medication overuse headache. The risk for medication overuse headaches appears to be highest with opioids and butalbital-containing combination analgesics. Narcotics may be prescribed briefly to relieve pain. These drugs should not be used to treat chronic headaches. Now let's start talking about prescription medications used for the acute treatment of migraine headaches. First off, the triptans. Triptans are a class of migraine-specific prescription drugs that bind to serotonergic or 5-HT receptors. According to current evidence, triptans remain the mainstay of acute treatment of migraines. They are considered first-line therapy for moderate to severe migraine, or second-line medications for mild to moderate attacks unresponsive to OTC analgesics. So for moderate to severe migraine attacks, triptans are considered first-line agents, and second-line agents there are several. For mild to moderate migraine attacks, OTC analgesics are considered first-line agents, and triptans second-line agents. Sumatriptan or Imitrex is the most extensively studied triptan. Here are some advantages of using triptans over other drugs. Triptans have fewer side effects than older migraine drugs, and in general, they are also less severe. They are not habit-forming. Triptans are a very safe class of medications. In Germany, Over-the-counter sales of Triptan and Triptan are allowed without prescription. In the UK, sumatriptan is available over-the-counter in previously diagnosed migraine patients. They come in various dosage forms including regular and dissolving oral pills, nasal spray, nasal powder, and injection. Let's take a moment to go back and review the pathophysiology of a migraine. Migraine headaches are characterized by neuronal hyperexcitability caused by the activation of the brain's central trigeminal nerve sensory pathways. This diagram shows the location of where the migraine is thought to begin at. It is at a key region located centrally in the brain that involves the trigeminal nerve. Release of neuropeptides. During a migraine attack, activation of trigeminal neurons trigger the release of vasoactive and inflammatory neuropeptides into the brain's nerves and blood vessels, inducing local inflammatory reactions. Calcitonin gene-related peptide, or CGRP, is a very potent neuropeptide produced within neurons. CGRP is the main chemical secreted from nerve endings in the brain during a migraine attack, and is responsible for many of the migraine symptoms. In this picture, the irritants that are released are these potent neuropeptides called CGRP. Notice how CGRP peptides cause blood vessel vasodilation with inflammation, as well as irritating the nerves to cause pain. Here's a simple diagram that illustrates the migraine process. First, a nerve impulse in the trigeminal nerve ending, in light green, causes the release of CGRP neuropeptides into the nerve synapse. CGRP then binds to the receptors on smooth muscle cells located in the cranial blood vessels in the cerebral artery and in the meninges. Activation of CGRP receptors results in vasodilation, inflammation, and pain occurring, leading to the migraine. Mechanism of action. Triptan drugs are serotonin 5-HT receptor agonists. They selectively activate the serotonin subtype receptors 5-HT1B and 1D in the brain. Triptans have a high affinity for 5-HT1B and 5-HT1D receptors and a variable affinity for 5-HT1F receptors. Triptans specifically bind to presynaptic 5-HT1D receptors on the trigeminal nerve terminals and dorsal horn neurons, and to postsynaptic 5-HT1B receptors on the smooth muscle cells of blood vessels. What are the effects of activation of these receptors? Activation of the 5-HT1D receptors located on the trigeminal nerve terminal ending in the brain inhibits the release of vasoactive and inflammatory neuropeptides, CGRP, substance P, and neurokinin A. This leads to inhibition of sensory pain transmission in the trigeminal system, blocking pain pathways in the brainstem, and leading to reduction of neurogenic inflammation of dura mater. Activation of 5-HT1B receptors located on the smooth muscle cells of intracranial blood vessels causes vasoconstriction of intracranial blood vessels, meningeal, dural, and cerebral, leading to a reduction of swelling and perivascular inflammation. Triptans bind to 5-HT1D and 1B receptors. As a result, they inhibit the release of vasoactive peptides, thus preventing CGRP from causing pain, vasodilation, and inflammation. Also, activation of 5-HT1B promotes vasoconstriction, thus inhibiting pain and inflammation. Here is a comparative table of triptan drugs that are currently available on the market. Sumatriptan is available in oral, nasal, and subcutaneous injection forms, while zomatriptan has both oral and nasal forms. The other triptans are only available orally. Amytryptan, L-triptan, and rizatriptan have an onset of effect of 30 to 60 minutes, and the longer-acting frovatriptan and naratriptan have a slightly delayed onset of action of about 2 hours, but owning a longer half-life and duration. All of the triptans are available in generic form. Dosages and maximum daily amounts are provided. Pharmacology. The shorter-acting oral triptans, sumatriptan, zolmitriptan, amytryptan, elatriptan, and rizatriptan, are similar in efficacy with 2-hour headache response rates of approximately 30 to 50% with maximum initial doses. The longer-acting oral triptans, frovatriptan, and naratriptan are better tolerated than shorter-acting triptans, but they have a slower onset of action and lower initial response rates. Intranasal and injectable triptan formulations are faster acting than oral tablets. Efficacy. Standard doses of triptans provide headache relief at 2 hours in 42% to 76% of patients, and complete pain relief at 2 hours in 18 to 50%. You can see in the diagram that sumatriptan reaches about 27 to 32% effectiveness. For headache relief at 2 hours, standard dose triptans alone performed equal to or better than NSAIDs. Acetaminophen and ergots were associated with less favorable outcomes. Recurrence with triptan use occurred in 17 to 40% of patients. When one oral triptan is not effective, others in the drug class may still provide adequate pain relief. If 3 migraine attacks have been treated without success with a triptan, patients are sometimes advised to switch from one oral triptan to another. Clinicians may also recommend the combination of an oral triptan with a fast-acting NSAID. Let's talk further about sumatriptan sub-Q injection. Sumatriptan given as a subcutaneous injection is the most effective dosing method since it relieves pain faster and more effectively than other forms. After sub-Q injection of sumatriptan, 60% of patients reported freedom from pain at 2 hours compared to 27 to 32% taking the oral form. Reductions in headache intensity typically occur within 10 minutes after sub-Q injection, within 15 minutes after application of the nasal spray, and after 30 minutes following oral delivery. However, sub-Q sumatriptan's use is limited due to higher cost, more adverse effects, and less availability than oral triptans. It is therefore indicated when a patient has a history of inadequate pain relief from oral triptans. Sumatriptan 6 mg sub-Q injection can be administered in hospital emergency rooms for patients with severe migraine, especially if the migraine is accompanied with severe nausea or vomiting. It is often accompanied by a parenteral antiemetic, for example, prochlorperazine, metoclopramide, or chlorpromazine. Adjunctive use of diphenhydramine 12.5 mg to 25 mg IV every hour up to 2 doses can also be prescribed to prevent akathisia and other dystonic reactions. Adverse effects. Triptans are generally well tolerated. Side effects include nausea, flushing, dizziness, drowsiness, fatigue, and tingling. Pressure or tightness sensations of the chest, throat, or jaw pain have occurred, but are generally not associated with myocardial ischemia. However, coronary arteries also contain 5-HT1B receptors, and as a result, triptans have the potential to cause coronary artery vasoconstriction. Hence, all triptans are contraindicated in patients with cardiovascular, cerebrovascular, or peripheral vascular diseases. This includes patients with a history of coronary artery disease, stroke, or uncontrolled hypertension. The use of triptans in this group may increase the risk of angina, acute MI, arrhythmias, and stroke. Here are some additional contraindications to using triptans. In severe renal impairment, naratriptan is contraindicated. In severe hepatic impairment, Sumatriptan and Triptan are contraindicated. Triptans should not be used within 24 hours of using another triptan or an ergot-containing medication because vasoconstriction could be additive. Concurrent use of monoamine oxidase inhibitors, MAOIs, with triptans can lead to additive serotonergic effects. Use of sumatriptan, rizatriptan, or zolmitriptan within 2 weeks after an MAOA inhibitor is contraindicated since it can result in increased serum concentrations of the triptan. CYP3A4 inhibitors. Use of elatriptan is contraindicated within 72 hours after using a strong CYP3A4 inhibitor due to increased serum concentrations of elatriptan. Acute treatment of migraine headaches. The ergot alkaloids. Main points. The ergot alkaloids are older compounds that were used for migraine. With the advent of triptans, the usage of ergots or ergotamine has declined, and ergots have largely been replaced by using triptans. In clinical studies, ergot alkaloids showed a lower efficacy to relieve migraine headaches at 2 hours than did use of standard dose triptans. Because the ergot alkaloids are vasoconstrictive, they are contraindicated in patients with cardiovascular disease, coronary heart disease, cerebral vascular disease, or uncontrolled hypertension. Triptans have a better adverse effect and safety profile than ergots. Therefore, ergot alkaloids should not be prescribed routinely to newly diagnosed migraine patients, and their usage should be limited. Mechanism of action. Ergot alkaloids are nonspecific serotonin agonists and vasoconstrictors. Similar to triptans, ergots are potent 5-HT1B and 1D receptor agonists. They inhibit trigeminal neurotransmission of pain at the 5-HT1D receptors and cause vasoconstriction of the pain-producing intracranial blood vessels at the 5-HT1B receptors. They also are an agonist of multiple receptors, including serotonin, adrenergic, and dopamine receptors. They cause constriction of both cranial and peripheral blood vessels. Ergots cause more side effects than triptans because of their decreased receptor specificity. We can see the location of where the ergots work at the 5-HT1D and 1B receptors. This is similar to the triptans. Here is a comparison table of ergot alkaloid products. Dihydroergotamine, or DHE, is available as an injection and in 2 brands of nasal sprays. The less used ergotamine is available in sublingual tablet, oral tablet, and suppository forms. Efficacy. Dihydroergotamine has demonstrated some efficacy in treating migraine, while the effectiveness of ergotamine remains uncertain. A systematic review revealed that dihydroergotamine was not as effective as triptans. Dihydroergotamine is available as an IM sub-Q injection and as a nasal spray. Intranasal dihydroergotamine relieved migraine pain after 2 hours in about 30 to 60% of patients during clinical trials. However, intranasal dihydroergotamine causes more adverse effects than triptans because of its decreased receptor specificity. Adverse effects of ergot alkaloids. Nausea and vomiting. Worsening of migraine-related nausea and vomiting is a common and a significant adverse effect with the use of ergot alkaloids. Ergots can produce dose-limiting nausea and vomiting, most likely due to dopaminergic effects at the chemoreceptor trigger zone. Pretreatment with or concurrent use of an antiemetic drug such as metoclopramide or prochlorperazine can reduce GI adverse effects. These antiemetics are dopamine receptor antagonists. The second important adverse effect of ergot alkaloids is vasoconstriction. Because the ergot alkaloids are vasoconstrictive, They are contraindicated in patients with cardiovascular disease, coronary artery disease, peripheral vascular disease, stroke, uncontrolled hypertension, and renal or hepatic dysfunction. The peripheral vascular constrictive effects of ergotamines are more pronounced than triptans, since triptans do not have activity at adrenergic and 5-HT2A receptors. Because of its vasoconstrictive properties, they can also cause leg cramps or tingling in the extremities. Dysphoria is another observed side effect due to central 5-HT1A receptor activation. Drug interactions. Ergots and triptans should not be taken within 24 hours of each other. CYP3A4 inhibitors that are strong. Concurrent use of ergots with strong CYP3A4 inhibitors is contraindicated. Triptans, beta blockers, dopamine, and nicotine. These drugs can potentiate the effects of ergots. Here's a summary. In Part 2A, we listed 5 advantages of using OTC medications for migraine headaches. We named 4 different OTC drugs that could be used for acute migraine treatment. We defined what a medication overuse headache is. We described the mechanism of action, main side effects, key drug interactions, dosages, and effectiveness of the following groups of drugs used in the acute treatment of migraines: triptans and ergots. What's up next? In Part 2B of this 3-part series on migraine headaches, we will learn all about the new classes of prescription medications used in the acute treatment of migraines, the gepants and the ditans. So stay tuned. Thanks for tuning in to watch this installment of the Farm Easy Tutor. I hope you learned something that you could use at school or in practice. If you would like to continue to see more of these types of tutorials on YouTube, please make sure to click on the black subscribe button below to change it to the word subscribed. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to black. Also, if you have any comments or questions, please feel free to add them in the comments section below or share this site with someone else. Stay tuned to the Farm Easy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.